I'm going to talk from what I know. Normally, when a practitioner pleads guilty and they get a fine, so they're actually admitting to guilt. So when they get that fine, they actually say, okay, this is what I've done, and I admit to it, and then you get an AG, admission of guilt, and they pay that fine. But if it's in dispute, then they're entitled to whatever the prelim has done or whatever transactions transpired, and then they'll have access to it so that they can refer to it and dispute it. Why they don't give it, I'm not sure. I can follow up and check from our legal side, but I'm sure if you had to request it, have you tried requesting it? But
so yeah, every charge we do request the minutes, but it's only if we dispute the charges, then I'll be given the minutes. It's a video recording of the thing, and you get a transcript. So if you do request it, even though they've chosen to, if you've chosen to accept the fine, that's it.
Yeah, I think if you have admitted to it and you're getting the fine, then there's no need for them to give you whatever's transpired, because you've already said, listen, I'm guilty, I take the fine. But if you're disputing, then they probably give you, I think that sounds fair.
Thank you. Any other questions?
Okay.
Somebody?
Maybe a question to Fatima. I've retired about 3 years now. One of the requests I get is from my family members, like my sister or my daughter. Dad, can you please give me my chronic repeat prescription? Can I give them a prescription for the chronic medications?
It depends what prescription you're writing, firstly.
Normal medication, like asthma medication, something like that.
I would say it's best to get someone else to prescribe it, because you know, medicine changes, new drugs come on the market. Somebody may turn around and say, you know, you didn't tell me about this new medication that came on that was better. It's just better not to write those scripts.
You're already on plan. You just want to see. You need to avoid doing the keeping it right. Give me a prescription, I'm on the following chronic medication. That's the thing.
You see, when you open your door a little bit, then it gets wider and wider. That's the problem. So I generally have a very nice approach to say, look, unless it's an emergency, I really don't write scripts. In the long run, I think it's much better for you. I just want to say that I did say I'm not representing the HPCSA today, and everything I'm saying is in my individual capacity. But the HPCSA regularly engages with stakeholders on an annual basis, or is it a biannual basis? And I think that is something the IMA should consider becoming involved in as well, because then you have a voice in terms of advocating for patients.
Thank you. Any other questions, Jay?
This is a question for Dinesh. Maybe, being a bit of a devil's advocate here, I suppose you could say all advocates are devils, but if you receive a complaint to the HPCSA, what's to stop you, as you say, contacting the patient and offering an out-of-court settlement or an agreement? Is it advisable? Because obviously then you can stop a civil case following up, and there's no ruling whether of guilty or anything. You don't have to admit guilt. You can say, listen, okay, I understand that you're unhappy. I'll give you your money back, pay you 50 grand, please go away. And in South Africa, actually, a lot of people will accept it. That's probably what happens in South Africa. No, I think that's the reality. How is Donald Trump managed to become president of America? So, I think, is that not a pragmatic approach where you don't admit guilt? Obviously, it undermines the ability of the HPSS to protect the patient, because you effectively driving the patient away from and a dangerous practitioner could continue practicing under those circumstances. We all don't want that. So that's why I'm saying I'm really a devil's advocate. I'm taking the lawyer's approach to this rather than the doctor's approach to this. So it's not a moral or ethical approach, it's a pragmatic approach. What do you think?
With ethical MPS and genoma, we do actually do that. You are allowed to contact the patient even though it's an HPCSA complaint. But unfortunately, once they put in that HPCSA complaint, there's this term called the law must take its course.
But can the patient withdraw the complaint?
Till today, we're still trying to get that done. The problem is that when we do send, they'll say, I'm going to let the HPCSA lady explain that process. Because unfortunately, once the complaint's in, it does take some time to withdraw it if they are willing to withdraw it. But what we're chatting about is mediation. And if you do want to call the patient in, offer them so-called hush money, I don't want to hear about it, but if you do want to offer them some form of settlement, it must be done under the premise of a mediation which is without prejudice, which means that whatever said in that mediation can't be used in a court, can't be recorded, there's no notes taken. So if you want to offer them a settlement, and often I said the settlement, we look for, in mediations, we look for high yield, low cost settlements. So you don't need to give them that 50,000. Often what happens is that when the patients are upset, if you reactivate, the whole point of the mediation is to reactivate the doctor-patient relationship. And often if you turn around and tell them, look, the knee replacement is septic, you owe 200,000 to the hospital, medical didn't pay, you put a complaint in. But now that you mediated, you can tell them, look, I'm willing to speak to the hospital to cut that amount down. I'm willing to do the operation at reduced rates. I'm willing to help you with physiotherapy, etc., etc. As long as it's done within a mediated settlement. Be careful with emails and not doing it through your lawyer or through MPS or through ethical insurance. Always do it under mediation, because whatever email you send and communication you have, that's with prejudice. That can be used in a court of law, and it's not something that can negate your claim. If you have informed MPS and then you call the patient on yourself to try and give them some money, and if MPS find that out or the patient complains about it or whatever, that can negate your claim, and you've got to pay for it after that. It's very interesting with regards to if a patient decides to drop the claim. Then have you been involved? Do you guys drop the claims? Or?
Yes, from our side, if we get an affidavit from a complainant to say that they withdrawn the case gets withdrawn. Because there's no complaint.
How long does it take?
I think the timing of when you do that is really important. If you proactively do that when the complication is arising, then the optics are great for you if the patient ever, because some of them complain despite that, and I would say the optics are fantastic for you because it shows that you tried to help the patient. Once a complaint is into the HPCSA, I would say it's a no-go zone, unless it's, actually I would say it's a no, because the optics look bad. It actually looks like admission of guilt now that the complaint came in, you started offering something. So remember, your panel is not all expert physicians. It's a range of expertise. So people look at how you do things. So I would say shared care.
Thank you for that. Time is up. So I'm going to allow one or two more questions.
Hi everyone. I want to know, what is the HPCSA stance on the medical schemes clawback act under Section 59 without having any proof of fraudulent activity, over-servicing, negligence? They basically just strong-arm healthcare practitioners into giving in to maintain their practices.
So the HPCSA don't deal with medical aid clawbacks and things like that. That's something that is dealt with the Council of Medical Aid Schemes and things. I think they've got a disclaimer at the bottom of the complainant. But the HPCSA can be, if the discovery or any of the medical aids find you guilty, they can then refer the case to the HPCSA, which is then that's where they get involved.
Okay, can we close? Is anything urgent at the back? Okay, can we take the last question?
In assessing standards of care, what yardstick does the HPSA use? Is there any difference for state doctors as opposed to private practitioners? If there is a difference, why?
No, it's the same for public or private. What is best practice therapy? what is reasonable care in the context of the situation.
Okay, thank you very much. I think that's the last question. And